Hello, this is a lecture that will go over school nurse supervision of LVNs and unlicensed assistive personnel. So starting off, let's talk a little bit about who are the people on staff who are providing those health services. And in the lingo of the schools, we call them certificated staff or classified staff. And it gets a little fuzzy because you think about certificated, credentialed, classified. Just for our purposes of this, certificated are those people who are credentialed. So a teacher is certificated, an administrator is certificated, a speech therapist, a registered nurse, etc. Everybody is certificated. And that usually means that they are assisted by someone in the HR department that looks into the credentialing and all that stuff, kind of handles it. It's a little bit more complicated in that way. So for us, this is the registered nurse credentialed certificated staff. Staff who are not certificated are classified staff, and that will be registered nurses who are, potentially bachelor's prepared, ADN prepared, but they are not credentialed. You might have an LVN, you might have what you title a health clerk or a health tech. You might call them generally an unlicensed assistive personnel. That's kind of an umbrella term for other things like a secretary or a paraeducator. People call them different things at different places, so just so we're all on the same page with our definitions. So let's talk a little bit about, but the difference between a school registered nurse and a registered nurse. So you are all registered nurses. You are all licensed. You have usually 2 to 4 years of education. That's really kind of general because we definitely have people who are new grads. You are credentialed, however, which makes you specifically a school nurse. You enter the school district with a preliminary credential that's good for 5 years, as you know. The district applies for that for all of their school nurses, and it's not automatic. So when people say, "Are you credentialed?" you say, "Oh, no, I'm preliminary credentialed." Well, that technically is credentialed. So you are acting as a credentialed school nurse, even though you don't have a full credential. You have a you don't have a complete credential. You have not had that. You haven't had the completion of your training yet. So you are technically a preliminarily credentialed, but you're still credentialed. Okay, so you can do everything a credentialed nurse can do. There's no limitations on it, except for you can't work past 5 years. That's really the only limitation without that credential. You are a licensed registered nurse by the state of California and potentially other states. You have a bachelor's degree of some kind, typically a bachelor's in nursing, but many nurses have a bachelor's degree in other things. I have a bachelor's degree in history before I have a bachelor's degree in nursing. Some just have one other degree. You will have a full credential. You have a preliminary credential in school nursing or school health services, and many credentialed school nurses also have a master's degree because not only do we value having that higher level of education in an educational setting, but school districts tend to value additional education as a means of awarding additional pay. Versus in the hospital, they don't really do that. They say, well, why do you need a master's degree? You don't really need one. So that's kind of a good thing. That's kind of a plus for schools. A registered nurse, on the other hand, would not have a credential but may have advanced degrees. You could have a registered nurse who's also an advanced practice nurse, an APRN, who has a FNP or an acute care nurse practitioner or a psych nurse practitioner. They do not have a credential, though. So even though you have an FNP and you have a master's degree, you still can't practice as a school nurse until you have that credential. Crazy, I know. Okay, so let's talk a little bit about the difference between an LVN and an UAP, or an unlicensed assistive personnel. I always have to say that slowly because it comes out so jumbled. An LVN in California is the same as an LPN, or licensed practical nurse, in many other states. Actually, most other states. I think there are only LVNs in California and one other place. They typically have a vocational training that's about 12 to 14 to 16 to 18 months, depending on the program. They do didactic in the classroom, and they do clinicals in different settings. They usually go to nursing home settings. Sometimes they will go to acute care settings. They're very much an entry-level healthcare provider. So they are licensed, though, by the state. So that means that they are required to follow the laws and rules just like you are. It's their own license that they are, practicing under. So it depends on the level of experience that an LVN might have as to what they should be doing. And some of them are really great and they portray themselves as being really great, and I think that's awesome, and they probably are very great, but we also want to be sure that we understand how great they are, and that comes with our doing our training and our supervision. Unlicensed personnel, on the other hand, they don't have a license. They are not overseen by any regulatory agencies in the state. They might have first aid and CPR training or just CPR training. Sometimes that's even a struggle, and they don't have it. They're typically on the job trained, and they may be doing UAP stuff for you or for the students as a side job to their main job. They may be the secretary and they're coming in and doing healthcare stuff. They may be a paraeducator in a classroom and coming into the office and doing healthcare stuff. So very, very different. So let's talk about the regulatory agencies and the regulations around being a nurse. So the Nurse Practice Act is set by the state legislature, and it helps to outline the scope and standards of practice for nursing. So this would be registered nurses, not specifically school nursing, but registered nursing overarching. And this is one of the areas that's been kind of a contentious between the Nurse Practice Act on the one hand and Education Code on the other hand. Both laws, but they live in different areas of the law books. So which one overrides, which one comes into play, which one you are adhering to and tied to, kind of depends on the time of the day and the thing that you're doing. You are technically adhering to both, but in the hospital, we don't ever let somebody else give meds. In the school, we do let people give meds. So you can see that there's a little opposition there, and there's nothing that precludes us from not letting meds be given in the hospital, except that it would not be great practice in an acute care setting, and the hospital's policies probably go against it. But there's a lot of other things, but it's not explicitly written in the law. But that's why we have a lot of discontent about some of this stuff that we do. So each state's Board of Nursing uses its respective Nurse Practice Act to create those rules and regs that define and help us clarify the things that we should be doing or our standards of practice. The Board of Registered Nursing is not there for you. They are there for the consumer. They are there to protect the public from you. So they set up the standards of practice and the rules and regs with the Nurse Practice Act, and they uphold the Nurse Practice Act by saying, did this nurse practice under the Nurse Practice Act? Did they practice within their scope of practice? Did they do what a diligent other nurse would have done in the same situation? And so when people say, I'm going to look up and call the Board of Registered Nursing, well, that's not for you to call because they're not there to protect you. And in fact, over the years, there have been some really big issues with the Board of Registered Nursing in California. Some, untoward behaviors, people being, it's an appointed position by the governor. When the governor changes, often that position changes. It's a political appointee. So, they sometimes aren't registered nurses. Sometimes they don't have any healthcare background at all. So it's a very weird thing. Also to note that California is one of 4 states that has both a Nurse Practice Act for the registered nurse and for the LVN. So we'll go to the LVN's Practice Act in just a minute, but let's stop at the scope of practice for a registered nurse. So what are registered nurses supposed to be doing? What's our scope of practice? In general, as an RN, direct and indirect patient care services that ensure the safety, comfort, personal hygiene, and protection of patients, and performance of disease prevention and restorative measures. That's pretty broad, right? We can put a lot of stuff underneath that real basic description. This doesn't speak specifically to the school nurse scope of practice, which is kind of lives underneath this and is more detailed in what we should be doing in the schools. But this is kind of that overarching. So let's go on. It's direct and indirect patient care services, including but not limited to administration of medications, therapeutic agents, those things necessary to implement a treatment, prevent disease, rehab patients that already have disease, that are ordered by and within the scope of licensure of a physician, dentist, podiatrist, and clinical psychologist. We also can take orders from advanced practice nurses and physician's assistants because they are working under also the physicians as well. So if you get a medication order from an NP, it's okay. That we can do. The performance of skin tests, immunization techniques, and withdrawal of blood veins from veins or arteries is also within our scope. So when people say, I shouldn't be doing immunizations, well, technically you should because it's in your scope of practice. Observation of this is where what separates nurses from everybody else. This is the assessment piece. This is our area of expertise. This is what you should come back to when you are talking about what you do with parents and families and administrators, is this last bullet here, which is observation of signs and symptoms of illness, reactions to treatments, general behavior or general physical condition, and determining whether the signs and symptoms, reaction and behaviors, or general appearance exhibit abnormal characteristics. So assessing if something is going on, knowing normal from not normal, and implementing, based on observed abnormalities, of appropriate reporting, referral, standardized procedures, or changes in treatment regimen in accordance with standardized procedures, or the initiation of emergency procedures. And the standardized procedures could be, nursing orders or standing orders or things that are just critically thinking we know those are the right things to do at that moment. So that's a really important and good thing to remember, look back at, use in your descriptions of yourself. So what does the LVN do? What's their scope of practice? Well, they are overseen by the Business and Professions Code, where we are overseen by the I can't remember, but we are the Board of Registered Nursing. It's under health and wellness, health and whatever, but they are under business and professions. So that's a little bit of a difference there. Ours is more, health-oriented oversight. LVNs must practice under the direction of a licensed physician or registered nurse at all times, under the direction of. Such direction may be provided verbally, telephonically, or written, so you can be indirect in your direction/supervision, but you must be the one who is directing them. So when you have a principal who's saying to you, "Oh, I don't want them doing that. I want them doing that," you can say to the principal, "Well, under the California Business and Professions Code and the Board of Vocational and Psychiatric Technicians, LVNs must practice under my direction. So I have to be overseeing what they're doing." And that means that if you've assessed somebody who shouldn't be doing a certain activity, and the principal wants them to do a different activity because they're rebel rouser, and you don't have anybody who's capable of doing that other procedure, and you want that LVN to do it, this is where you really need to kind of shake that cage and step up. Because it's if the principal just doesn't want to do it just because he doesn't want to be called to task by that LVN who just doesn't feel like doing that or doesn't feel like it's within their job, and he wants to avoid conflict and tells you to train somebody else, stand up and say no. The LVN may assist in the collection of data during assessment process. That means assist. That means they are not doing an assessment. They are assisting you in an assessment. So what does that mean? It's a little bit vague, and it needs to be within a, what's the right word here? It's something that you are part of. They are not doing it for you. They are assisting you in doing it. So maybe you're in the room together and they're getting the vital signs. Maybe you're in the room together and they are comparing the feet in a foot assessment, and you're looking at one foot and they're looking at the other, or they're double checking you, something like that. They can also provide validation of assessment data, so that would be kind of double checking what you're doing, but the assessment itself must be done by the registered nurse. So they're assisting and helping to validate. The LVN may perform part of the triage process that includes they can interview, observe, they can collect subjective and objective data, and recognize problems that are abnormal conditions that are specific to that particular patient. So this is a little vagueness. This is during a triage process. So for example, if they are in a health office by themselves, they can ask, did you trip? Did you fall? Did you land on your hand? Did you land on the other hand? Yesterday, did you have a scratch like that? Do you have a scratch like that today? That kind of thing. That is very appropriate for them to be collecting those things during a triage process. They can also do life-saving measures like CPR, and they can manage assaultive behavior in like that kind of setting if that's necessary. So how do we collaborate as RNs and LVNs? We both have licenses. LVNs should be treated with that measure of respect, because even though they have quite a bit less training, they still are licensed. They have met a measure, an objective measure at the state level to be able to hold that license, and they are accountable. So we should treat them as licensed providers, and we don't want to kind of pigeonhole them into not doing anything because we're afraid, and we want to utilize them to their full scope of practice, and that's really important, and bringing them in and collaborating with them rather than kind of saying, you go over there and I'll be over here doing this great work and you're going to sit over there and dig the ditches. That's not okay. They do need to work under your direction. We've covered that. And it's up to you to really look at, as I mentioned earlier, what should they be doing? What are they capable of doing? Some are really good at doing stuff, and others, some are good at tasks, at those specs, those specialized physical health care procedures. They're really good at treatments. Others are good at talking to people and, working with the kids in the health office. So, anyway, it would be up to you. Data collection may be done by either the LVN or the RN, but the RN may evaluate the data to decide on the action. So the LVN, again, can take that triage information. They can do things. They can make decisions like calling the parents. They can call to clarify orders that they are carrying out. They can do that kind of stuff. But the registered nurse really needs to be the one to decide things that don't have a physician's order, that are kind of major decisions. The analysis, synthesis, and evaluation of that data can only be done by the nurse, and the nurse can initiate, evaluate, or change the student's treatment or care plan. The LVN cannot do that. They can monitor the patient for the registered nurse. The registered nurse manages the patient. And so when you're telling them what they need to be doing, you're not going to say, well, you're only allowed to. You can only do. Try to phrase it in positive ways. It's really important that you monitor the patient, because I'm not there to monitor, and your role is to monitor, and you're really good at monitoring. That's why you're here, and that's what I'm trusting in you. That kind of thing. Be positive as possible with them so that they feel like they are part of the team. All right, so what about the care provision, the provision of care given in the for students in the health setting, in the education setting? This goes back to Ed Code 49400, which says that the governing board of any school district shall give diligent care to the health and physical development of students and may employ properly certified persons for the work. So, diligent care. What does it mean to be diligent about something? Now, I might think that diligent care means a registered nurse with a credential in every single building. Someone else might think that it means that we can do kind of a team approach where we have some credentialed school nurses, some LVNs, and some unlicensed people. So it really depends on the situation and the people in your district who are calling the shots and paying the money. So who are those qualified designated persons? Well, Ed Code 49423.5 says that any student with exceptional needs who requires a specialized physical health care service, a SPEC, can be assisted by a credentialed school nurse or a certified public health nurse. Public health nurses don't necessarily have to be credentialed, but they have to be officially a PHN licensed by the state. And, that this doesn't happen very often because most PHNs don't work in the school setting, and they wouldn't necessarily know how to manage the school setting because they don't work there. They don't know the laws and rules and all those nuances about the school setting. But technically, according to Ed Code, they can do this. Or they can be assisted by a qualified designated school personnel and perform those services under the supervision of the school nurse, the PHN, or the MD. So those qualified designated school personnel. So what does it mean to provide that diligent care? Well, you handle those health and medical needs of students. Health could be mental health or physical health. You fully support them to get FAPE, which is free and appropriate public education. So if it's appropriate for them to be in school because they have diabetes and they need help, then you're helping secure FAPE for the student by providing diabetic services. And then you also, to do diligent care, you're going to follow the state and federal laws, including nursing licensure. All right, so let's talk. We're going to kind of jump around a little bit here. I'll try to keep the flow going, but talking a little bit about the school nurse and diligent care and oversight of others. The school nurse is the legally recognized school health authority. While others can provide those services, they are the ones who are recognized legally as the school health authority. That's the power you have. So remember those words and use those words. The school nurse is a registered nurse licensed under Chapter 6 of Division 2 of the Business and Professions Code, who has completed the additional education requirements for and possesses a current credential in school nursing pursuant to 44877. And the school nurse, with that training, this training you're in now, the school nurse is especially prepared and uniquely qualified in preventive health, health assessment, and referral procedures. The registered nurse also has the authority to recognize the qualifications and abilities of unlicensed assistive personnel and LVNs to perform those healthcare tasks in the schools, in the stead of the school nurse when the school nurse is not there. So when an RN is providing supervision, they must assure that the people, the subordinates, the people who are providing that care are clinically competent to perform those functions that they've delegated to them. Otherwise, bad things happen. It's true that LVNs practice on their own with their own licenses, but by the RN, as I mentioned before, has to recognize that the LVN scope of practice is limited, and they have to understand that they must be under the direction of the LVN and must tell others and remind others and have those codes and numbers and things ready to tell the principal and whoever else that they have to direct their practice. The RN, from whom the CNAs, we don't really see CNAs in schools very much, but if they were, it'd be a CNA or a UAP or an LVN or an RN or others, receive their assignments from, or to whom they are accountable, has supervisory duties. This is true whether the work title says RN supervisor, school nurse supervisor, district nurse. The RN, if they give an assignment or they give tasks or they're responsible for the tasks of others, they are the supervising nurse who has responsibility for that care provided. They still need to assure that the care is being provided correctly and fully. So more about the registered nurse. The RN must directly observe the patient. The RN must analyze, synthesize, and evaluate the data that might be collected by themselves or by the LVN in their triaging and helping. The RN then uses the data to make a nursing diagnosis, and that's not that NANDA nursing diagnosis thing. That's just a nursing diagnosis. That's just a phrasing of what's going on. They have to determine appropriate interventions and make appropriate assignments of tasks, referrals, all that good stuff. The LVN does not initiate, evaluate, or change any treatments or the care plan, also known as an individualized healthcare plan in the school. They can participate in planning. They can carry out or execute an intervention per the treatment plan or the care plan or the IHP. They can contribute to the evaluation of interventions related to the treatment, so they can make sure that the student doesn't have any side effects from the treatment or that they're not throwing up after they've been given a pill, but they're not going to do that full assessment like the RN does. So what does a UAP do? A UAP, again, is a school staff who is not licensed versus the staff who are licensed. Just a little bit more of the same, a different way to see it. The LVN might be a district employee or an agency employee. If they're a district employee, they typically are in the health office staff, depending on where you are housed, if you're housed at a school site or district level, or they might be assigned to a particular student within the entire school district or within a school site. It really depends. they might travel from school to school, just like a registered nurse or a school nurse does. An agency LVN will be contracted by the district, typically short-term, or provided by the parent for some students who might have like a Medi-Cal provision that allows them register LVN time, and they might utilize that time for the LVN to come during the school day. So what are these physical healthcare procedures we're talking about? The definition is that physical healthcare procedures or services are those healthcare services that are prescribed by the physician or surgeon or APRN or PA that require medically related training for the individual who performs the services and which are necessary during the school day for the child to attend school. So you, as a registered nurse, have had medically related training. So that pertains to you, but you already fit within that description. The training that others need to have would be the training that you provide for them if they are performing the specs when you're not there physically, or when you are there physically, but they're doing it in your place. This question comes up a lot. Who can provide services? I believe there is something in the class that is a chart like this. If there's not, I will make sure that there is. And as you can see, that the credentialed school nurse does everything. And the registered nurse can do a lot of things. And sometimes we put maybe on these if it's specific to something that's going on for the student. So for example, the individualized healthcare plans, creating an individualized healthcare plan or an emergency care plan, they theoretically could do something like that because registered nurses do create care plans. They just don't do them in the school setting, and they're not specialists in like child development or school assessments, but they could really assist the nurse in doing those, and it would not be too far from their ability to do that. Specialized physical health care services, training and supervising, they could do that because technically they are an RN, and they could do that. Maybe these RNs are PHNs, and if they are PHNs, public health nurses, they could definitely do that. They may not feel as comfortable because they're not working in the schools necessarily. They just have they're public health nurses. So that's why we put maybe in there. It really depends on the circumstances. Specs, providing direct care. Yes, nurses can do that. Credentialed can do that, of course. Registered nurses can do it. An LVN can do it if supervised. An unlicensed person can do it if supervised. And then the ed code is on the side there. So you should be able to utilize a chart like this or this chart to be able to see who can do what in the school setting. So this is kind of just that piece that I talked about pulled out a little bit so that you can see it up close. So, as you know, the Nurse Practice Act does not give you the authority to delegate nursing tasks and functions that require a lot of thinking, assessment, skills, things that only registered nurses have been trained to do, making decisions about whether or not to give a medication, making decisions about whether to hold a treatment based on, an assessment. A child feels nauseous, you hold the treatment. That's pretty basic. But so we cannot delegate UAPs or, we can delegate LVNs because they can make those decisions because they are licensed to do that, but we're overseeing them and making sure they're able to. But UAPs cannot be given those tasks. And so sometimes you say to yourself, well, gosh, giving tube feeding does require assessment. So does providing, diabetic care. That does require assessment. Yes, but it's pretty standardized decision making in those cases. Those are typical everyday things that those students have going on. And what we're talking about here is giving an RN level decision making cannot be given to a UAP. So the authority for UAPs to provide specs is conferred by ed code, not by license of the nurse or by the physician. So ed code says that UAPs can do it. The nurse then is responsible to make sure that the UAP is adequately prepared to do it and capable of doing it, but it isn't the license of the nurse that decides whether or not a UAP does something. It's ed code, and it's kind of out of our hands at that point. The American Nurses Association and the National Council on State Boards of Nursing provide a joint statement on delegation. You can search for this on Google, and it gives you the ins and outs of when to delegate and when not to. An algorithm, answer yes, no, and it takes you down the line. I suggest you go ahead and do that. Utilization of LVNs is that RNs may delegate to LVNs. What about special ed assessments? This comes up a lot. The answer to that is no. They cannot do special ed assessments. Any health assessment of pupils shall be made in accordance with sections 56320 and shall be conducted by a credentialed school nurse or a physician who's trained and prepared to assess the cultural and ethnic factors appropriate to the pupil being assessed. So a physician can do it if they're trained. They are all trained. But LVNs and UAPs should not be doing any part of a special ed assessment. All right, in the school setting, who supervises the UAP and the LVN's activities? Did you say it to yourself? Yes, the school nurse is the supervisor. So how do we effectively supervise LVNs or anyone? The supervisor of care, as you've read and heard, is a school nurse, a public health nurse, or an MD who's qualified to perform the procedure or do the work of supervision in a school setting. The level of needed supervision is determined by the school nurse. Since we're really talking about school nurses, we'll come back to the school nurse. You get to decide. Is it direct care, direct supervision? Is it indirect supervision? What level does the person need to be overseen? You have the privilege to decide and specify that level of supervision based on your professional judgment. And you will advise the IEP team of that decision as needed during the meetings. And you can provide your assessment data and your assessment information about that. One thing to remember is that no matter what level of supervision that you have decided you will provide for the LVN or the UAP or the RN, you need to document every time you provide that supervision. This can get overwhelming. I realize it. Some people will be documenting all day, every day is all they do. But make sure that you're writing down everything that's going on, even if it's just jotting a few notes. It doesn't have to be extensive. But you should also periodically observe them doing the procedure. You trained them once, they did a great job, then you never see them again. That's probably not a good idea. Set up a regular schedule for observations. And then you want to confer with them, even if you're not seeing it, you want to confer with them on a regular basis, checking in, how's it going? Think of a couple questions to ask that would be things that might help you to get an idea, because they're going to say, it's great. And you want to have that, some good questions ready so that you can ask them what's going on. And then you want to review their documentation periodically as well. All right, so what are the levels of supervision? So what is the level when you're making decisions? What is the level of care that's required? Does it require a school nurse or a registered nurse? Does it require a licensed person but not a registered nurse level or a school nurse level? Or can it be somebody who's unlicensed? What is the training that you should provide or that should be provided to the RN? That would be like a non-credentialed, an LVN or an unlicensed person. Providing that initial training, getting a return demonstration, and then periodic observations, regular periodic observations. And then what type of supervision are you going to provide to them? Immediate supervision, direct or indirect? Immediate is that you are there when they're doing it. You're there when they're needing you. Direct supervision is you're overseeing them at all times. You're right there with them the whole time. Indirect is that you are available to them at all times, but not necessarily physically on the spot. Ongoing supervision will be provided then that you're going to periodically observe. You're going to confer with the staff and the person providing the care and those around them and review their documentation. So then when you're looking at the continuum of care, who needs to provide the services? You're deciding how do I decide who I want to give care to? If they are medically stable, they're not complex, it's the same typical care they get all day, every day, a UAP would be completely appropriate. If they are medically fragile, if they're complex or changing, if they're getting treatment changes or things are different many days or most days, that would probably be better for, or they have some kind of treatment that requires, something you're not completely comfortable with and getting comfortable with. Sometimes trachs are a little nerve-wracking, so registered nurse, school nurse might be better for that. And somewhere in the middle will be the LVN, because sometimes when we say they're medically stable, not complex, there's a little bit of a nuance to that. Medically fragile, complex, but then they stabilize. Maybe we could throw the LVN over there. So it really is a fluid thing that you're making decisions based on. So when you're thinking about delegating, you want to make some considerations for whether or not to delegate. So in this case, you're going to look for things that are routine for the pupil. Remember that the things that we do in the schools, we are in loco parentis, we are the parents for the day. So if the parents are doing it in the home regularly for the child, then it's routine for the pupil. Often people say, oh my gosh, we can't be doing that. In the hospital, we would never do that. It's really dangerous to compare yourself to the hospital, because the hospital is very specific. It is acute care. It's not normal for people to be in the hospital. Often they're in the hospital because they are sick with things that they've never had before. They are sick because they need a change in treatment. But the kids in the school, typically, it's very routine. It's something they're doing all day, every day. It poses little harm for them. So is it routine for them? Does it pose little harm for them? Does it typically have a predictable outcome? Yes. Okay, so this is why we can provide normal diabetic care for stable kids, usually, and with those with pumps and continuous monitoring. If it doesn't require an assessment to make a decision on whether or not to do something during the day, or interpret a lab before you do something, or some kind of decision making, these are all, if you answer no to all of these, then you can be pretty sure that delegating this to an LVN, an RN, or a UAP is probably going to be okay. I like to tell people, don't be too dramatic, because often we don't want to have to do things because we're a little afraid of it. And so we say, oh, it's really scary, but they shouldn't be cared for if they're diabetic, and it's something takes getting used to, right, when you first get to the school setting. But those children are doing their own care from very young age, and their parents are doing care for them. These are people who never had medical background, and they're able to care for complex diabetic students. We can do the same for them in the school setting, and we have licenses, so we can do that. All right, so remembering that the level of care might be typical every day, but it's also affected by certain things. So it's not always the same. Their health status might have changed, and in that case, you want to decide. So you're kind of looking at this on a daily basis. Is the child still the same? Is it still stable? It's Tuesday. Yesterday was Monday. Things have changed today. Make a different decision. That doesn't mean that you can't have the LVN off the case and you on the case if that's what needs to happen, if things have changed and that level of care was affected by something. So just because the LVN's there doesn't mean that they should be there all the time. Always be assessing. ABA. Always be assessing, right? If things at home have changed, if there's a complexity or a change in procedures, or something in the school environment has changed, their schedule changed. I know my daughter has had a change to her lunch and her nutrition schedule 3 times in the last quarter, which is ridiculous. But that can change and can throw kids with medical needs off. If they have something going on with them that you need to support, the adrenal crisis, you need to support them, the standard of care has changed, or the caregiver competency has changed, or your LVN calls in sick, or something happens like that. All right, so talking about training, who in the school setting trains the LVN and the UAP? All right, yes, of course, it's the school nurse. And it's defined by Section 3051.12 of Title V, California Code of Regs, a credentialed school nurse, public health nurse, or licensed physician or surgeon. So technically, the public health nurse is also able to train. So I should have that highlighted as well. But in this case, we're talking about the school nurse. All right, so what do you want to go over when you're training anyone on providing care at any level? You want to be sure that you cover what are the general principles of care for all kids, and then specific to that thing that they're doing, provide that care, that training, that task that they're providing. What are the general principles of care? So where can you find this information, this general written information about the condition? You can find it from credible websites, Mayo Clinic, CHOC, CHLA, Johns Hopkins. Try to find some credible information. There are a lot of organizations out there, like the local epilepsy society. They have a lot of great information. Doesn't preclude you from using them. Avoid .coms. Of course, you want to get like the latest and greatest. And then student-specific training in the assigned task, which is something their doctor's order. Doctor's orders don't always cover the exact written procedure. They just say, give 30 cc's of X, Y, Z, once an hour. The written procedure is either something that you have developed yourself or that you have sought from a school district that has written procedures that you've adapted to fit the needs of your district. That would be something like San Diego has great procedures, Orange County has great procedures. The Specialized Physical Healthcare Guidelines book from CSNO, formerly called the Green Book, they have a bunch of written procedures. It costs to have that book. I think it's $300 or something, but you can buy certain procedures. I know we may have spoken before about this, but I highly recommend that book. Your district should invest in it with all of the money that they have for materials, for testing materials for your school psychs and your speech therapists. School nurses should be able to also procure necessary documents and tools to do their job. So ask your manager to get you those specs from the guidelines from the CSNO. And you can just go to their website, and it's cheaper if you're a member. You want to show them the procedure, demonstrate it, and then get a return demonstration from them. Let them know how to respond to those. Show them that written guide, which is the ECP, the Emergency Care Plan. Provide them instruction in how to document what they did, and then write down your verification of training and the disposition of the person you trained, i.e., were they able to do it? Did they have difficulty? What was the plan for follow-up, etc.? So if you have two LVNs and one was able to do it and the other one really had difficulty hooking up the little plug to the other plug, and she just couldn't, she was older, she had arthritis, she couldn't put the plug in the plug. What went on? What do you plan to do? Did you go ahead and assign that person, or did you pull back and say, I'm going to retrain again in a week and try again? I know that in my old district, we had one person who we just were not sure whether she could do it or not. So we went every single day and trained again every day, watched again every day, and then we handed it off, and then we went every day and watched. So we would do it the first week, hand it off for the second week, and the third week we came a couple times during that week. But it took a lot of training to get that person up to speed. It's never too much, right? You don't want them making mistakes. You want to be sure that they know what they're doing. You want to keep copies of everything you gave to them in a file. You probably already have those. You want to document when the training occurred and the outcome. That's that green box that I had on the other page. And if more than one return demo from the trainee was appropriate, document that they gave you more than one because you asked them to, because they had difficulty, etc. Keep a record of the training. This is from the CSNO specs book, and this may have changed. They did update the book. But, as you can see here, there's checklists, there's areas for notes, how you trained them, and then you can put this into the book that you keep about the training to keep a record of what's going on. All right, we talked a little bit about this level of supervision already. These are a little bit out of order. Sorry about that. Immediate is you're physically present while the procedure is done. We did immediate supervision for that second week with that person I was mentioning earlier. Direct supervision is that you're there and you may be right with them, but you may be just in the building, or you may be just available, but you're on site you're around nearby physically. Mostly we provide that indirect supervision, right, in our schools, because we are going from school to school. We have remote offices. It means that they can email us, call us, Zoom with us, whatever it is, but we are indirectly supervising what they're doing. But don't let that get too loose. be sure that you are definitely supervising them, even if it's indirectly. You can do the reverse, not just that you are available to them, but that you can call them and they are available when you do call them. Okay, so this is from Title V that talks about the differences in these levels of supervision. And remember that indirect supervision means that the supervisor shall be available to the qualified designated school person either in person or through electronic means to provide necessary instruction, consultation, and referral to appropriate care and services as needed. Supervision of designated persons shall include review on site by a qualified school nurse, public health nurse, or physician. Supervision shall also include a review of the competence of the individual performing the specialized healthcare services, maintenance of appropriate records, physical environment, and equipment. So those are the things you're required to do in indirect supervision. It's not just a nice thing. You have to. So when you supervise, when do you want to do it and how often? It's going to be based on your professional judgment and on the health status of the student and on the complexity of the task. So considering all of those things, how often and what level of supervision, and you can be fluid in between those. You could do immediate supervision to start with. You could just back off a little bit, but be in the building. And then finally, you can be out and about and be indirectly supervising. All right, so when we think about the components of supervision, we're looking at their competency. The person is trained and ready to go, that you've documented every instance of supervision and training, that you've looked at them doing the procedure, you're doing that periodically, you talk to them periodically, and you review their documentation periodically. Again, this is kind of repetitive, but it is hopefully getting you, putting it into your brain over and over again of what needs to be done. And you're probably doing this already, or you're finding areas where you could improve and do better. There are documents also within the specs book that allow you to document the evaluation of staff in performing different services. This is just an example. You probably can't see it, but you'll want to evaluate and review. Now, you're not doing evaluation like your principal does an evaluation for a raise. Now, you may be contributing to that, but you are annually or more frequently, usually it's more frequently, reviewing how they're doing when you're popping in to see them, and you're documenting it. And there are just page 2. And NASN has also some documents as well. So if you're an NASN member, you'll find some different resources to utilize as well. Also, other local districts might have some good ideas of things to use. If you don't have the specs book, you don't have NASN, you just want to make your own, whatever works. All right, so issues of liability always come up when we're talking about training other people to provide services. And so the question always is, I'm going to get in trouble on my license because they're working under my license. No, nobody's working under anybody's license. The unlicensed assisted personnel work for the school district. They don't work for you. They work for the school district. And if you've done your due diligence, which is to assess with your judgment that they can provide that service, you've documented it, you've understood that they are able to do that, it's delegated appropriately, they are under the direction of the principal. And you are providing training for them, but the principal is deciding what they're doing. An LVN works under their own license. Now, you are overseeing them and you're supervising them and you are directing their care, but they work under their own license. That's why you have to stand up when principals want to say, put this person here and not this person, because, it might take you more training to train someone else if you had to go back and do a different training on a person that you didn't think was as qualified, but it would be worth it. If the principal is going to try and undermine you and take away the well-trained person and put somebody else in there, you just need to, perhaps you're going to have to either be immediately supervising that person for a while, or maybe that you just have to do the procedure yourself. So you need to be assessing as you go all along. So when you assign a healthcare task, what you're doing is you're transferring the responsibility for completing it to another person, but you are still accountable for it to be done appropriately. That means that you need to be assured that the UAP or the LVN knows what they're doing, so that when you're transferring that responsibility, that they are doing it the way that you trained them to do it, and the way that you saw them doing it, so that you can be accountable for them being able to carry that out. Okay? Really heavy duty stuff. That's why you want to be sure that you're documenting everything and observing and doing that good indirect supervision or direct supervision. This is really basic stuff. Remember back to school nursing 101. That first year you were in nursing, document, chart. The documentation should be accurate, concise, and timed and dated. And typically, the medical record is not what brings to the attention of people who want to sue the district. But what happens is people sue the district and then they bring the medical record in or the school health record in, and that either really crappily done or non-existent record is what increases that value of the lawsuit against the district or enables the lawsuit to move forward. So you don't want to be that person. You want to make sure that you document and you are accurate and concise, even if you're just jotting a note down. Sloppy documentation equals sloppy care, and no documentation means no care. So you don't want to be in that position. More on documentation. So if a UAP or an LVN does something inappropriate, if you cannot demonstrate with your written documentation that UAP was trained, or the LVN, and show that with your written documentation they successfully carried out the procedure with your supervision, direct, indirect, immediate, in the past, then the school nurse puts the license in jeopardy. And you don't want to put your license in jeopardy. So be sure that you're writing everything down. Here's some basics. Back to basics, baby. Date and time, sign every entry, make them immediately after the care has been given, be legible, be thorough, accurate, objective, only used appropriate abbreviations. Don't make abbreviations up. Document all interactions with or about a student, face-to-face or over the phone or in a discussion with other people. Remember that the record serves as a log of communication that provides insight into what was said, when it was said, and who said it, and their response, specifics about what's going on. Here are some documentation things that you can make sure that you have when you're providing spec training for others. A training checklist, a supervision log, a healthcare contract, or an IHP. I'm not sure where the contract thing comes from, but the individualized healthcare plan or the nursing care plan, or a contract with the family, emergency care plan, the healthcare procedure, and the doctor's orders, any daily logs, and any additional notes. Sometimes, as I mentioned earlier, the LVN is contracted to provide care in the school district. It might be contracted by the parents, might be contracted by the district. The agency nurse, or it could be an RN as well. So an agency nurse works under the supervision of an agency supervisor, not under you. But your concerns about an agency nurse should be reported to the agency supervisor. You do have to oversee what the LVN or the RN is doing with the student. So if they're carrying out physician's orders in the school setting, you should have a copy of those orders. You should have a copy of the logs. You should have a copy of everything. You should orient that LVN or that RN to the school. Give them your phone number. Let them know that you're going to be overseeing what they're doing, and not necessarily overseeing them. You're not supervising them, but you're going to be overseeing what they're doing. While you are not responsible for that person's care provided because you are not their boss and you are not the one training them, you certainly are responsible for that child who goes to that school, and you care about the child who goes to that school. And so you want to be sure that the care being provided is appropriate. Sometimes an agency nurse can come in and they're not doing things the way that you might want them to. And so you want to call that supervisor, but you also want to intervene before you have to call and let them know that you're there. Let them know that you are there to talk to and ask questions of, and you can help them troubleshoot and call their supervisor. So don't shirk that responsibility just because you don't want to have it. And I understand that. Remember, though, that this is about the student. Now, we had LVNs doing care for children that had a trach in our school. And so I wanted to see what they were doing, and I got a copy of the doctor's orders. It looked funny to me. I called the RN, who was the agency supervisor. We talked about what was going to happen. Also, that nurse had to go on breaks, and so we had to be sure that we covered that person for her breaks. So there's a lot of other little nuanced things, and instead of seeing it as a resentful thing for me, that I was like, I don't want to have to do this, it's an extra job. Yes, it's an extra job. It's part of the provision of care in the schools, and it is what it is. And so, make it as best you can, protect the student. Orient the agency nurse to the school site and the safety practices there, who to talk to, where to get things. Be available to interpret district policy or tell them about district policy. Orient them to the classroom and to the teacher, and the teacher to the guidelines. So you're going to introduce the teacher to the LVN, let them know what the LVN is supposed to be doing, kind of be that go-between, be a collaborator. The site administrator, the principal, needs to be overseeing everything, though. They should be knowing about the time, the schedule, the services to be provided, who's responsible for what, how to contact the supervisor. They should be giving that information to you, but they often don't. Typically, it's you. I'm a go-getter. I don't wait for somebody to give it to me. I just find out myself. I suggest that for you as well. If you wait for the principal or site administrator to do something for you, you may end up being disappointed. So while it's their responsibility, ultimately, if you want to get your job done, you might as well just do it. Same procedures if the agency LVN is provided by the parent. All right, so sometimes we get questions about whether or not one should work outside of their scope of practice. Of course not. The Nursing Practice Act and the scope of practice guide what you're supposed to be doing. But there are times when people feel that they could provide the best care to their patient if they could just do this one extra thing, or this thing that may not be what's in their job description or their job scope of practice or their license scope of practice. They bend the rules. Everyone agrees that bending the rules is very risky business, and once you bend them, it's hard to bend them back. There's something known as responsible subversion. This is when a healthcare provider acts responsibly by putting the patient's or the student's best interest in the forefront, but at the same time, they're acting subversively by stepping outside of the rules of their practice. Once you've bent the rules and you had a favorable outcome from peers, supervisors, everyone, you're going to be tempted to do it again and kind of continue to work on that outside edge of what's appropriate. Then it becomes acceptable practice. And once you start bending the rule, then you start bending a little bit more, and it's harder and harder and harder to come back and even remember what the rules were. So basically, don't do it. A violation of the Nurse Practice Act is very serious. It can result in a complaint being filed with the Board of Registered Nursing. They utilize their authority to decide whether misconduct is safe or unsafe practice has occurred, and then they decide what action should be taken. They take it really seriously. Very seriously. I've known several different cases where people had licenses revoked, where they paid a lot of money. One person, she ended up paying the Board of Registered Nursing because they had to do an investigation. They charged her back for the investigation of $20,000. So just don't do it. Work within your scope of practice. However, I want to talk a little bit about the scope of practice. I might have another slide here, but it's your responsibility to not work outside of your scope of practice, but it's also your responsibility to work fully within your scope of practice. That means that it is malpractice or negligence to not do the things that are within your scope of practice. So if you're shirking around kind of going, well, that might be outside my scope of practice, I'm not going to do it, I don't want to take a chance. That's not the way to go. We're not saying do things that are outside the scope, but you need to fully work within the scope. So if your scope of practice says that you should be doing health teaching, but you're like, I don't want to do health teaching because it's too much, and a diligent nurse would have done that, that's a bad example because health teaching isn't really something that you would have, get in trouble for. But you get my point that you should be practicing within your scope of practice fully. So don't shirk things just because you are unsure. Know your scope of practice. The board may suspend judgment, which is to say, okay, we're suspending judgment, but you have it on this note on your license. They might put you on probation. They could suspend your right to practice for up to a year. They can revoke a license. And they can discipline, which means that they can do different things like charge you money, which is really bad also. LVNs can have their license revoked or suspended. They can be on probation also. They can also have an issue. They can also have a citation or a fine, or have to enter a remediation program depending on the infraction. Remember that the school district or your union will only defend you in a legal case if you are working within your job description and within your professional scope of practice. So get your hands on your job description. If they don't have one, you need to demand that they have one for you. And if they're telling you to write your own, let's get that together for you so you have a good job description that fits and within your scope of practice. So your scope of practice book, you should have a copy of it. It's one of the required books for this class, but also you should have a copy, and they are updating it regularly, so you want to have the most updated version. If you are found to be operating outside of your scope of practice, or you're not fully working within your scope of practice, whether or not harm comes to the student, you could be suspended or license revoked. Here are some resources. Be sure you have that scope and standards book, and then look into those specs, those guidelines, to have them so that you can always fall back on those. If you're ever questioned, you can say, I'm working within these guidelines. This guides our care, judge. And then, you never will be called to task. If you make something up and you're just kind of doing it, winging it, because that's what's always been done, you may be at a little bit more risk. So, all right. If you have any questions, post them on the Q&A board. Otherwise, I hope you have a great rest of your day.